a special guest here today. I'm going to read you her bio. It's Jhana Wilson, physical therapist. She works as a home health physical therapist for CenterWell Home Health Agency in Silverdale, Washington. Jhana earned her physical therapy degree at University of Santo Tomas in 2011 while living in her country of origin, the Philippines. She immigrated to the US in 2014 and has been working in different transitional care units and long-term care facilities before switching to home health practice. She is very well versed in treating individuals with neuromuscular diseases, including FSHD, and specializes in seating and wheelchair assessment, which is very important. She's experienced in the intricacies of Medicare and Medicare maintenance program for individuals such as those with neuromuscular diseases. And we welcome Jhana and we thank her for coming to share her knowledge with us. I'm going to let you take it over, Jhana.
Thank you, Renee. Hi, I'm Jhana. I'm very thankful that I'm invited to this group. I always like to educate all of my patients on how to set their goals in physical therapy, what physical therapy can do for you, and like long-term planning or goal setting is also very important with FSHD. So I will be sharing it's a PowerPoint and we'll go over different topics, but I will mainly focus on maintenance physical therapy because that is something that you would qualify for. And what are the requirements in order for you to receive that type of service? So maybe I'll try to share my screen. Let me go back here. We'll go.
I see it.
All right. You guys see it?
Yes, thank you.
All right. So I'm going to start with what is skilled therapy service. I will be mainly talking about physical therapy, but I can also answer questions as, what occupational therapy, what speech therapy can provide. So this is just a content disclaimer that everything that will be provided for today's presentation especially for Medicare benefits, is based on what is currently published, and that I do not endorse any business entity or products that may be mentioned during the presentation. So these are the four main topics of discussion: what is skilled therapy service, FSHD, and other chronic conditions, and how are these conditions important in order for you to receive maintenance therapy? And then what is the referral process? How do we initiate that? So what is physical therapy? So for physical therapy, I think most of us, you probably have an idea what we do in the field, but to summarize, it's mostly we improve patients' physical function. It could be addressing their strength or addressing their impairments. It could be limitation of motion. It could be reduced activity tolerance. Also, we don't talk about managing symptoms of chronic conditions, but we do a lot of education, not only prescribing exercise, but teaching patients on how to monitor your symptoms and what are the signs and symptoms, when to call like your primary care physician, or what symptoms are needed to be addressed right away. And lastly would be recovering or preventing injury. And that also includes education on maybe how do you go about doing a certain task, preventing yourself from injury, especially if you do have muscular imbalance. There might be a different way or technique that you're used to that could potentially increase your risk for pain. So I want to focus more on this rehabilitation frame of reference. And I'm always excited when I talk to patients about goal setting. When you get a referral to physical therapy and a physical therapist ask you, what is your goal? And most of the time when I ask my patients, what's your goal? What do you want me to do? What goals do you want us to set? And what interventions do you expect me to provide? And most often than not, patients would give me either a very specific answer or a broad answer. But do we know how do we achieve those goals? Is anyone willing to share an experience of like talking to your therapist and kind of talking to them what your goals are? And how do you go about deciding what goals to work on? Is there anybody who would like to share? Yes, Darlene. How do you I think Darlene raised her hand.
I did.
Go right ahead, Darlene.
I was trying to unmute myself. Yeah, several years ago, I had a total knee replacement. And because initially my health insurance had rejected the type of knee replacement I wanted, I had to do a lot of research so I could present to my health insurance carrier why I needed that knee, that specific knee, and it centered around my muscular dystrophy and whatnot. So I got it, and then I got a physical therapist, and I was lucky because her specialty was knee replacement. And so, you go through the first week stuff, it's pretty easy and everything, and they just kind of work you into things. And one of the things that I had read in all my research was for range of motion, you have a very narrow window,
right,
to get full range of motion back. And it was my dominant leg. At that time, it wasn't affected a lot by the muscular dystrophy. And I think it was like in my second week or so. I had full range of motion back by the end of my second week, which is, I guess, pretty incredible. But she said to me, Darlene, your range of motion, you're doing really good on that. I want you to work more on your strength exercises to get your strength back. And so I asked her, I said, can we discuss this a little bit more? And she said, sure. And I said, from my research, I see that I have a very narrow window for regaining my range of motion. And she said, yes. And I said, I have muscular dystrophy, and chances are this leg is going to be affected probably in the fairly near future. I can't have a leg that I can't use without range of, that is stiff and also be losing muscle. And I would prefer to work on range of motion, and I can work on strength as I go along, but I want to make sure I have my full range of motion back first. And she looked at me and she goes, that's a good point. And that's what we did. So I got full range of motion back, and I managed to keep that and then work on strength. And then she shared, I felt like she shared more with me and opened up more to me because I had done some research and I knew what my goal was or what I wanted to do.
Thank you, Darlene, for sharing. I always love when patients tell me what their goals are, what they know about their current disease or impairments, because that helps us achieve your goals. And ultimately, our goal is to promote as much independence and improve your quality of life. And most of the time when patients are having a hard time to explain what their goals are, I try to teach them these three approach. And these are the three that we can help you navigate with. The first one is restorative approach. And I would use Darlene's example. She wants to be able to restore her range of motion. So that is a restorative approach from a physical therapy standpoint. So some impairments can be restored. So limitation of motion for her, getting that range of motion back is what they work on in physical therapy. Now, some impairments cannot be fully restored. And that's why maybe goal setting for you will be more of a compensatory strategy, which means it could be changing the way how you do a certain task, or it could also be trying a new equipment. For example, some people who have not been using a cane, maybe after a knee replacement surgery, you might want to compensate first by using an assistive device. So you're still restoring some of the impairments, such as range of motion, but you might want to compensate in order for you to still be safe. So another good example for a compensatory approach is, I think for FSHD, it's also common to have loss of strength in your ankles. So some patients would present with foot drop. So maybe considering a use of a brace or an AFO for your ankle, that is a compensatory approach in order for you to still be able to safely transfer or ambulate from point A to point B. And then the last part of intervention or goal setting is adaptive. And when we go to an adaptive approach, it is mostly doing a lot of setup. It could be environmental modification in order to make sure you're safe. So it could be maybe remodeling or adding grab bars in your bathroom in order for you to safely transfer in and out of your toilet, or maybe using like setup from family members. So you still want, some patients would tell me, my goal is still be able to go to the bathroom and do this, but it might be a taxing effort for them to gather everything they need. They need to get their clothes and other hygiene care materials in order for them to do that. So maybe an adaptive approach for that will be, how about let's set up your environment, let's set up your bathroom, so that way when you get there, you still have the energy to take care of yourself. So when we set goals, it doesn't necessarily mean that you have to do a restorative or a compensatory or adaptive. Sometimes you have to use all of these in order to maintain that level of independence at home. Do you have any questions as far as goal setting? All right. And we will talk about more about each one when we talk about maintenance therapy moving forward. All right, all right. So what is skilled therapy service? And this is quite, I would say, controversial, because this is how Medicare pays for our service. And most of the time, I honestly have used this in the past. I would tell patients, well, what I'm providing to you is no longer skilled. And most of them are like, what are you talking about? You are a skilled clinician. So if you are a skilled clinician, then technically you're providing skilled service. But Medicare defines skilled therapy service with these 3 points. So one, the service has to be complex, and that will require a knowledge of a skilled clinician in order to complete the service, the modality or treatment. So this could be under physical therapy, it could be occupational therapy, it could be speech language pathologist. So the complexity and sophistication, number one, you do want to do a systems review. So what are the impairments that the patient present? Is it something that can be addressed by like another person that does not have the knowledge of a physical therapist? And also the type of interventions we're providing, do we need to constantly assess or monitor patients' response to exercise that we need to modify consistently, or provide different exercise if their condition vary daily? And then the second one would be that these skilled services must be reasonable and necessary. And, you know, with Medicare, they do have funds, but it's not infinite. So I think with this, it's mostly us clinicians. That's why we do assessment and constant reevaluation, is to provide a reasonable dosage of how much do you need, how much therapy sessions do you need in a week or in a month. And then the last one would be services must not be dependent on the beneficiary's potential for improvement, which I think most of us would think, oh, I need to progress in order for me to continue physical therapy. But progress does not necessarily validate that the service provided was skilled. And one good example of this would be, maybe I did an assessment one day, and the patient skipped 2 weeks of physical therapy. When I came back, this patient showed significant progress, but I did not provide any service. So Medicare kind of looks at that like, well, even the patient showed progress, it doesn't mean that you provided something valuable to the patient. So another thing to take note of for the progress is that Medicare does not have any improvement standard in order for you to receive the service. So it doesn't mean that you have to constantly progress. So what they look at is how much skill are we providing to patients? And we'll talk about more on that moving forward. So what is rehabilitative versus maintenance? So I think goals would differ from rehabilitative and maintenance. So rehabilitative would be a goal to improve a function, and maintenance would be more of like slowing down the progression. And I think most patients who do have a neurological condition, that you expect that the progression of their disease can impact their function in long term, maintenance program might something that you would want to consider. So these are muscular affectations for FSHD. So we all know that it targets skeletal muscles. So weakness is number one. And most often than not, we always target strengthening, but we all know that progress is not going to be shown consistently. It can vary day to day. Some days you might be able to do 5 sit to stands, and then some days it might just be 2. So why are we talking about muscular affectation, and how do we connect that to maintenance therapy? Because we know that the magnitude of decline varies from one patient to another, that we might want to consider having a skilled clinician to assess your condition and provide the necessary interventions. And it can be, some patients would need a change in their program every month. It could be every 2 months. And that's why maintenance therapy could be beneficial for you. And another very interesting topic would be, what are the extramuscular manifestations, and why are we talking about this? Because chronic conditions can impact your daily activity. So aside from muscular weakness, these are the things that you might be experiencing that can compound the disease itself or the symptoms. So respiratory abnormalities, and it's most likely due to muscular imbalance and wheelchair dependency. And curvature of the spine can also increase your risk for respiratory failure. So one of the things I really like to look at, especially for muscular imbalance, is, do you have a proper wheelchair support? If you're a wheelchair user, do you have a proper backrest or a seating surface that can, provide proper body mechanics? Because if you have muscular weakness and muscular imbalance, just being able to maintain your posture takes an effort. And towards the end of the day, you get tired. So during, the span of that long period of time you're sitting up, you do want to provide as much postural support to your muscles so that you'd be able to you still have the energy to perform other tasks. At the end of the day, you don't need to rely from caregivers to help you with transfer. So, and then one of the things that are very prevalent would be the pain. So 79% of patients would have pain, chronic pain. And we know what chronic pain does to patients. So it can lower your ability to participate in any activity. It also increases your risk for falling, because most of the time, if you're in pain, you don't want to you don't want to get up, you don't want to move. And that leads to more progression of the muscular weakness, and that can increase your risk for falls. So pain alone, that is something that physical therapists can address. It could be maybe teaching you positioning techniques. It could be maybe teaching you what stretching exercises that can be done, or maybe providing some even strengthening exercises, which is functional. So meaning teaching you how to do a certain activity. How do you compensate in order for you to stand up safely with less pain? Or another one would be a back brace might be helpful. So things like that we need to constantly assess and monitor in order to provide not just a skilled service, but also meet your goals. So like I said, how can maintenance therapy help reduce risk for falls, reduce hospitalization, potential reduction of loss of function or slowing down the progression of the disease, and potential reduction of symptoms associated with chronic condition? So we're not totally targeting the reason behind those loss of function, but we are trying to address what can be compensated, what can be adapted, and then what are other tools that we can use, such as assistive device. Is it time to look into using a wheelchair? How do you maybe pacing techniques throughout the day? And then these are the myths. So you probably have heard it. Your physical therapist would say, oh, we don't provide any maintenance therapy. I'd like to know if you've heard this phrase before, that physical therapists don't provide any maintenance therapy. And I would say I'm guilty of that. I used to say that a lot because that's how we were trained. We were trained to rehabilitate. But then during the course of my career, I realized that, oh, I'm actually providing some form of maintenance therapy in a varying degree, because you always treat patients who do have a progressive disease, such as Parkinson's disease. So sometimes I would be teaching them techniques how to do it in order for them to maintain a certain function. So I don't think that is accurate. We do provide maintenance therapy. And then the second one would be no rehab potential. And I talked about this a while ago, that Medicare does not have any improvement standard. So no rehab potential, I personally think that we're probably looking at one impairment. You kind of have to really assess the patient as a whole and to see what can you do for them to make it better, like everyday activities better. So I actually made up these questions. So it's maintenance physical therapy for you. So number one, do you need physical therapy to slow down the progression of FSHD or prevent decline? I think everybody would say yes to this question. And then second, will an established home exercise program no matter how complex the exercise, can you repeat it daily without any changes? And this means like if you have pain one day, can you still do the same parameters, like same repetition, same sets of exercises without any modification? It varies because some days you're probably gonna have less pain than other days. So this could be maybe no. If you answer yes, if you can consistently do your home exercise program without any modification, then maybe maintenance therapy is still not for you yet. Okay, Dan raised his hand.
Yes, Jana,
Hi.
I was diagnosed many, many years ago, and I was told at one time, and many of us that have had FSH for a while were told, you know, not to exercise. And then we were told that, or I was told, that my activities of daily living could supplement exercise. So when it comes to can we do an exercise program daily, knowing that we have on days and off days? How much of our ADLs can be considered exercise supplement or exercise on a daily basis?
That's actually a good question. First, and this is why whenever I do see patients, especially patients with neurological disease, and I know that their symptoms can vary, I like to teach them to use an exercise diary. So we started a very low intensity exercise and kind of giving them, oh, these are the 3 things you need to be able to do. It could just be maybe try to work on your sit to stand 5 times in the morning and 5 times in the afternoon. And then just do, I'll give them maybe 3 to 4 exercises to do. And that's going to be their baseline. And I would only have them start their exercise diary if I know that after few sessions with them, they're able to do that consistently. So it doesn't have to be, a whole day you're exercising, but maybe targeting just functional exercise like sit to stand and really working on your exercise diary, because that's how you're going to be able to see what you can tolerate. So having that list, and then what are the activities that you're doing daily? So maybe having a specific day for shower, because it's a taxing effort to do a shower. Shower is not just being able to, shower, dress yourself. It is a whole day task for some people because you need to be able to prepare, gather everything you need, get into the shower, do your shower. So the exercise program can vary daily. So you might be able to just do your shower in one day and maybe don't do all of your exercises. And that's why I think having a physical therapist to help you guide what are days, which days can you do these exercises and which days can you probably skip, because it changes daily. So having a good exercise diary will help you what you can tolerate. How can you pace yourself and also schedule some activities of daily living that's taxing. I also teach patients that yes, it is an effort for you to go to the bathroom and do your shower. Or yes, it's an exercise for you to be able to walk to and from the bathroom. But most of the time when you do that, I tell patients, well, I think in my opinion, it's not exercise, because most of the time when you go to the bathroom and then come back, your goal, your mindset is, I just want to be able to get there and get it done. So you don't really think about, how am I breathing when I'm walking? Am I able to pick up my leg better when I'm doing this? And am I using more of my arm muscles, or I'm trying to engage some of my leg muscles when I'm doing it? So dedicating a time to actually do very light exercise, I wouldn't expect that you'll be, lifting weights or doing a mile of walking. Having some form of exercise in the morning and afternoon, just low intensity, I think will be beneficial in order for you to still function daily without getting too exhausted. Did I answer your question? Do you have any more follow-up?
No, thank you. That's very complete. Thank you.
All right. And then going back to the maintenance physical therapy is the third one. Can this exercise be performed by a patient and or caregivers effectively? So one of the things that Medicare looks at is, do you have a caregiver that can assist you with exercise? So sometimes yes, sometimes no. Sometimes it depends on the complexity of the home exercise program that's being provided. And also some pain can arise with some exercise. Do you think your caregiver can identify or can assess your pain level or what's causing that pain? Maybe not, too. So this is why maybe having a physical therapist initiate those programs for you, and then having a maintenance therapy to constantly assess what you're able to do. Is it time to modify your exercise? Is it time to maybe progress a little bit? I've seen patients who still have some progression and we need to change their home exercise program. And then the last one would be, does the program require the skilled therapist to assess your response? Or does it need modification on a regular basis? So these are the questions that I think should guide you and should guide all therapists on providing maintenance physical therapy. So I think if you keep answering yes, except for number 3, then it might be something that you'd want to consider. But I'll be honest, this is something that most physical therapists are also not familiar because of audits and Medicare denials. So we have been, I think, in our profession, we have been doing a lot more education across all clinicians on what maintenance PT, how do we actually document, and how do we qualify, or how do we assess a patient in order for them to qualify for this type of service. So there's still a lot of teaching that needs to be done, not only to patients what they can receive, but also to the clinicians. And most of the time, that's where the disconnect is, because there's lack of understanding and education of how do you qualify somebody for a maintenance physical therapy. And maintenance therapy will be 3 points. You want to stabilize the function, slow down the progression of the disease, and still facilitate functional independence. And functional independence or safety, it could be doing your activities of daily living. So maybe in the morning, you're able to walk to and from the bathroom with a walker, but in the afternoon, that could be more of a taxing effort. So how do we keep you functional enough to do it and safe to prevent falls? So those are the type of goals that we target in maintenance therapy. And this one is this settlement agreement. This was done back in 2013. And basically, Medicare did not expand their coverage. They basically just explained or clarified that skilled services provided by a PT, occupational therapy, or speech therapy, I think even nursing, they do a maintenance nursing program, that it is still necessary to slow down further deterioration. It's not based on the absence of potential or improvement or restoration. So yes, Medicare covers maintenance therapy. So how do we initiate maintenance therapy? So under Chapter 7, so skilled maintenance therapy is covered by Medicare if one, skilled therapy service, if the inherent complexity of the service is such that it can be performed safely and or effectively only by a skilled therapist. So, and even if you do have a caregiver that can assist you with exercise, some of the exercise that we provide or teach patients, you still need skilled therapists to actually modify those. So for some patients, in terms of dosage, some of them don't necessarily need three times a week or even once a week. Sometimes you might have to start once a week and then maybe go down to once every 2 weeks because they get to a point I still want them to be as independent as possible doing their exercise, right? You don't want to kind of help them to do everything. So usually for skilled maintenance therapy, I don't provide like 3 days a week or once a week. Sometimes if, let's say, they had a fall and we need to kind of work on more of a restorative approach again, then I might have to increase my dosage. And then as they kind of plateau, then we can go back to just once every 2 weeks. And then second would be patient's clinical condition requires specialized skills, knowledge, and judgment of a skilled therapist to design the program. Do you think your caregiver can teach you like what exercises to do? So those are the questions that you want to answer in order for you to benefit from this type of service. So where can you get maintenance therapy? So where can maintenance therapy be performed? So we do have outpatient setting, skilled nursing facility, and home health. So exceptions would be inpatient rehab and comprehensive outpatient rehabilitation setting, because most of the goals for these type of setting are restorative. So I actually never had maintenance therapy experience in an outpatient setting, but I've had in skilled nursing and home health. And like I said, dosage is different. It's not going to be sometimes a weekly thing. The ones that I think needs a higher dosage would be somebody who has a significant contracture. So contracture program, I do provide a lot more frequency for them, especially if some people would have a significant contracture that even their caregivers can provide hygiene care or shower, things like that. So those are the type of maintenance therapy that can be provided in a higher dosage. And across all setting, outpatient, skilled nursing, and home health, basically they all say the same, that you don't need the potential for improvement in order for you to receive it. So I think I just wanted to ask, is everybody like in a home health, home setting? I will be talking about more Medicare eligibility for home health services. Because I think this is also like applicable for those who are in independent living facility or assisted living facilities. So one of Medicare eligibility for home health would be confined to home. We will talk about more of homebound status later. And then you need skilled service. You need a physician, and that receiving services under a plan of care established and reviewed by a physician. So when we do write our plan of care, we send it to the doctor, and your primary care physician or nurse practitioner has to approve the plan before we can provide the service. And then the last one would be you need a face-to-face encounter with your doctor. I think there might be different criteria each state. So you might want to ask your therapist or your doctor well, because some states are different, like they're in terms of plan of care. But I think for state of Washington, once we get a referral, after referral and evaluation, we still have to send it back to the doctor. I know in some states, once you get a referral and you do your assessment, it's kind of okay to see the patients for 8 weeks. So homebound status is #1 criteria for home health service. And so they do have 2 criteria. The first one, at least one of these 2 should be met. And the first one would be because of illness or injury, you need a supportive device such as cane, walker, wheelchair, you need a special transportation, or you need another person to assist you in order for you to leave your house. And the second one is having a condition wherein leaving home is medically contraindicated. Most of the time I encounter one is what most patients would meet. Number 2, you always need to have your doctor's justification why leaving home is medically contraindicated. But the second criteria, both of these should be met, which is there must exist a normal inability to leave home, and leaving home must require a considerable and taxing effort. So homebound status, and one good example for this is if you have to go to your doctor's appointment and you come back home, do you need to rest more than 3 hours? So meaning going out to even get your go to a medical appointment is already a taxing effort. So what they just want to make sure is home health appropriate for you or outpatient? So the outpatient setting, if you can tolerate being able to go to the clinic, do your therapy, come back home, and still be able to do your activities of daily living, then maybe you're not considered homebound. But if one really good example is going to a medical appointment, you come back home and you need to sleep, you need to rest for 3 hours, then you are definitely homebound. But Medicare says there are considerations. So it doesn't necessarily mean you cannot leave your home, but you can with one, infrequent periods. Second would be you need to receive a healthcare treatment. So going to the doctor, getting a procedure done, maybe a lab draw. And then third would be going to church or going to like special occasions. So graduation, trip to the barber, things like that. So for the referral process, the referral doesn't have to be written specifically for maintenance. Most of the time, when we get referral for therapy, we would get, physical therapy for strengthening. And then we do our assessment, and we might want to start with a restorative approach, and then we see that the patient is no longer progressing, but they still need the skilled service. So sometimes we have to change our plan of care to maintenance. But also there are patients that I have seen for, let's say, the past few years, and you can tell that after multiple referrals and discharge from therapy, you see that they have been declining. So maybe right then and there, you would qualify this patient for a maintenance therapy program. And the second one, I just added this, communication between patient and medical team is important to reduce confusion as to goals and interventions that will be provided. Because at the end of the day, if we are going to go through Medicare, your goals has to be specific for maintenance, and the treatment you're providing is specific for maintenance. All right. I think we're going to do a Q&A. Maybe you guys have a lot of questions. Hi, Dan. I think you have to unmute.
Here we go. So this week I came across a company called the Stretch Lab. And I feel that if I'm more flexible in having one-on-one stretching, that my physical therapy would benefit me better. So have you heard of Stretch Lab and going to one-on-one stretching sessions? What are your thoughts about that? This is a new one for me.
Is it, I have not heard stretch, I haven't heard of them, but is it a physical therapy program? Is it a clinic that you have to go to?
Yes, it's going to be an outpatient facility. They call themselves flexologists. I do believe they do have physical therapists and other quote unquote physiotherapists that are staffing there. But what I'm told is I'll be seen by a flexologist. My first session will be tomorrow, which is the initial evaluation, and then we make a plan of care from there.
So are you asking me about like the effectiveness of like stretching program for FSHD?
No, I guess I'm looking for if you've heard of them, good or bad, and what your thoughts are on stretching along with physical therapy maintenance program because I can't stretch myself.
Right. I think stretching is one important intervention, especially for FSHD, because you do have muscular imbalance. So one part of your, it could be this, your abdominal muscles might be more of a stretch muscles, while the backside could be more tight. So having that muscular imbalance can also impact pain. So I think stretching would definitely help to reduce symptoms of your pain if, and they're going to do an assessment. So they'll be able to like tell or check which muscles needed to be stretched. So I think it's very important. If it's like a low intensity stretching, I would definitely approve of that.
Okay, so as long as I'm not having pain.
Yes. Oh, Renee actually sent the link. All right. I would have you to read more about them.
So are we sure that it's run by physical therapists?
I believe they have physical therapists on staff, but the majority of the staff that do the stretching with their clients are called flexologists,
Oh, okay.
which I don't know. You know, they talk about going through an extensive training session. I don't know who oversees that. Do they have medical direction behind them? Yeah, this is all new to me.
Well, good for you for checking it out.
Yeah.
I know one of the ladies in the WOW group identified a new service called Luna. Has anybody heard of Luna?
Yep.
Could
We
look
do
that one
have,
up too.
we actually have Luna around here, Renee. I know some
Okay.
therapists
And
work with them.
they come to your home?
They do. It's a home health service. I think they do cater more in Seattle side, but we do have some here in our county.
And do they so they've got their own physical therapist on staff?
It is similar to home health, but I could be wrong. I think I read that Luna actually bills through Part B services. So I could be wrong on that, but I think somebody said that they actually bill through Part B instead of a Part A.
Okay. Okay. Yeah. I thought that was very interesting. So are there any people that are attending today that are in a maintenance program now?
Yeah.
Well, I reached out to my physical therapist last week, and she says that they are beginning a physical therapy maintenance program. They're still kind of working out the bugs, and I think that means they're still trying to figure out how they're going to get payment for maintenance therapy. Um, but yeah, I've scheduled the first session for next week, so I think I'm going to learn along with them how it goes. But
Yes.
she was telling me that we would likely do a once a week maintenance, 1 hour maintenance session. And there are other things I can do at home, but the majority of my physical therapy that includes mobility and balance, it's very difficult for me to do it safely at home. In the physical therapy gym, I was in parallel bars, had a gait belt on me, and I felt much more safe and comfortable with having somebody spot me. So that's my goal for getting into their maintenance program is to continue to work on gait and balance.
Yes, absolutely. That is great, Dan.
Any questions for Jana about exercise, concerns she might be having about being able to do X, Y, or Z?
I have just a question, kind of about equipment, and I'm not asking for endorsements or anything. I'm just asking. I was told that I needed to use a recumbent bike that had, I can't remember what they call it, but so nothing you have to step over to get on it. You just a step through. That's the word that they used. And I find the recumbent bike difficult for me because when I'm sitting upright, I can pedal more easily. When I'm recumbent, I lack the muscles on my inner legs to hold my knees together. And then I'm using my joints weird. And somebody suggested using a belt to hold my legs together or something. And I'm wondering, are different recumbent models, would it be different? Like when I had my knee replacement, I think I was on a recumbent bike, but I don't remember like being so reclined as I am on the one I'm on now.
Yeah, I honestly would not recommend a sitting surface that you are slightly in a reclined position, because that would actually make you use compensatory muscles instead of targeting your leg muscles. And most often than not, you might be using a lot more of your back just to hold your posture, and then you'll have more back pain. I don't know if you have seen an omnicycle. So basically, if you're using a wheelchair or a chair, you can move the chair back, and then you can put your feet onto the pedal, and there's a strap. So, and it also has a leg strap in order for you to maintain positioning for the legs. That is, I think, something more ideal for people with FSHD instead of, recumbent bikes wherein maybe some of the backrest also is very tiny, so it doesn't provide as much support on your back. And sitting surface is very important when you're using a bike, because you want optimal positioning of your pelvis. Because if you have a better, a flat surface where you can sit, it gives you a more stable support. It gives more support on your spine. And then also, how is your backrest positioned in order to maintain your spine in neutral? So a new step would be good. Sometimes I recommend, I don't endorse a specific product, but I think it's called QB. So something similar to that, wherein you can bring your chair in front of that as long as it's up against the wall, then you'll be able to like use your leg better rather than using your back muscles trying to maintain your posture.
And how do you spell that last one?
It's C-U, I think B-I-I.
Okay.
It's just an ergometer. So they yeah, it's not, it also provides resistance. So you can, I think, go from 1 to, it varies. Their models would say up to 8. Some of their newer models it goes up to 10, I think. But you don't have to necessarily get that particular band, but similar to that one.
Right, just to give me an idea of what I'm looking at.
Mhm.
So, thank you.
Well, thank you very much, Jana. We really appreciate your coming and sharing your expertise with us. It's the top of the hour and we want to be respectful of everybody's time. So thank you very much.
Thank you,
Thank you very
Renee.
much.
I'm very grateful to meet everyone. Yeah, I love educating my patients about what services we can provide and what can be expected of physical therapists. And I think having that understanding will be helpful in order for you to set your goals.
And in
Thank you very
full
much.
disclosure, Jana is my physical therapist with the home health agency that I participate with. And she does all the things that she says. She's extremely sensitive to stretching and what my needs are and how my body's changing with the lovely disease. And she's very good with educating as well.
Where are you
Can you come
located?
over for a group session, Renee?
I'm sorry.
Can we come over for a group session one day?
Sure, take the ferry when it's running really well. The ferry's wonderful. It's delightful. Yeah, we could do a group session.
Well,
Where
thank
are
for
you
putting this
located?
together.
Silverdale, Washington. It's across the pond from Seattle,
Okay.
Kitsap County. It's beautiful out here.
It is.
If you're a hiker, you like the outdoors, we do have a number of trails that you can use your wheelchair on.
Really?
Get outside.
Mhm.
I grew up in Alberta, Canada, so I do miss the hiking and being out in nature a lot. So
Yeah, I'll bet. I'll bet. It's beautiful there too. Well, thank you, everyone. And we'll let you know when this one gets ready to be posted for the YouTube channel.
In action. Thank you, everybody.
thank
Thank
you.
you. Have a good day, everyone.
Bye
You
now.
too.
Bye-bye.
Bye.
Thank you, Jana.
Bye,
Thank you
Renee.
very much.
I think Greg will be seeing you this week.
Okay.
All
I
right.
figured there was order problems because I know Daniela wasn't able to come because she didn't have any orders. So I thought I hadn't heard it from anybody because there weren't any orders.
Oh, I called Dr. Rad and they said that they no longer provide verbal. So
Oh, okay.
I had to fax everything.
Bless you. Keeping up with the times. Keeping up with the times. Well, I'm going to let you go. Thank you so much.
Thank
That was
you.
excellent. Excellent. All right. Bye-bye.
Bye.